wish to invite all of you, all the teachers, faculty members for this teaching program, especially our teachers, Dr. Purushothaman sir, Parvati madam, Janaki madam, all teachers of all the medical colleges who have helped us to reach to this level. Thank you very much. Now let me hand over the mic to Dr. Shiji. Thank you.
Thank you, Sunil sir. Very good evening and welcome once again to everyone, senior members of the forum, dear friends, and my dear postgraduate students. Today we will be having an excellent case discussion on a child with fever with arthritis. Our lead faculty will be respected Dr. Santoshkumar, Professor of Pediatrics and Medical Superintendent, Azizia Medical College, Kollam, and Dr. Alka Madhavan Kutty, consultant pediatric cardiologist at Amala Medical College, as our faculty come mentor. And the case will be presented by Dr. Parvati Pradap, Lakshmi Pradap, junior resident at Amala Institute of Medical Sciences, for you all. The stage is yours, doctors. Thank you.
Lakshmi, you can start.
Good morning, sir.
Good evening, Lakshmi.
Good evening, sir. Can I start presenting?
Yes, yes. Am I audible, Lakshmi?
Yes.
Yes, sir. You are audible.
Good morning, good evening, sir. So, presenting the case of a 12-year, 11-month-old male child.
How much time we have? 1 hour. Huh?
Sir, up to 9 o'clock. Up to 9 o'clock.
We can go up to 9 o'clock, sir.
So, Lakshmi, then can you start with giving your final diagnosis? What is your diagnosis?
Sorry, sir, I didn't hear.
Sir, volume കുറച്ച് കുറവാണ് സാറേ. Sir, volume
Sir
കുറച്ചും കൂടി.
has asked you to start with your diagnosis.
You can give your diagnosis first, so that our history can be. No, you need not go to the diagnosis slide. You can just give the diagnosis.
Sir, I wish to tell my differential diagnosis. First differential diagnosis is post-streptococcal reactive arthritis. Second is acute rheumatic fever. And third is incomplete Kawasaki disease.
Okay, then you start person.
So, presenting the case of a 12-year, 11-month-old child, male child. The information was given by his mother. The presenting complaints was fever for 10 days and pain in the right.
Previous slide, I think it is a typing mistake. No, that date must be a typing. So, 2021. Right. Next.
Fever for 10 days, pain in the right knee joint for 5 days, and redness in the bilateral eyes for 5 days, and pain in the right hip joint for 1 day. History of present illness. About 13-year-old male child who was developmentally normal and immunized for age was apparently normal, now presented with complaints of fever, which was continuous in nature. Fever was high grade, temperature was not recorded, and it was not associated with chills or rigor. And the temperature relieved on taking antipyretics, and there was no associated diurnal variation present. History of sore throat on first 2 days of fever present, no cough or no associated rhinitis, no swallowing or breathing difficulty was present. On second day of fever, mother noticed rashes over upper. On second day of fever, mother noticed rashes over upper limb and lower limb, subsided within 2 days on applying a lotion, and the rashes were papular, non-pruritic, and non-erythematous. No history of any oral ulcers or perianal desquamation.
Can you tell us why you are asking for oral ulcer and perianal desquamation?
History of rash is present. So to rule out whether any mucosal involvement is there, I ask about the history of oral ulcers, sir, and perianal desquamation, which it was a fever for.
When you are specifically asking for ulcer, you have something else in mind, I think.
Yes, so this is a long duration, about 10-day history of fever. So it can be whether it is a SLE, systemic lupus, or
Good. Okay,
I
good.
asked about
What
oral
about
ulcers.
perianal excoriation? Why?
Perianal desquamation, since it's a long duration of fever, it can be Kawasaki disease, sir. So for that, I asked perianal desquamation histories.
Okay, but your diagnosis post streptococcal something, no? So can streptococci produce perianal desquamation? Okay, leave it. Proceed.
Okay, sir. And from day
Locally, it can produce, but it may not be part of the system.
Okay, sir. From day 4 of fever, child had complaints of sudden onset right side knee joint pain that was not relieved on taking any analgesics. Pain was severe in intensity and the child was unable to walk. And the knee pain was associated with swelling and redness of joint.
Excuse me. This sore throat started along with fever, no? So the duration of sore throat is also 4 days. Am I right?
Yes, sir. So the sore throat was present only on the first 2 days, and they treated that sore throat and it resolved, sir.
Okay. But the duration since sore throat is only 4 days.
Yes, sir. From the first day of
duration
fever.
Since throat. Okay. 4
on
days.
first 2 days of fever, history of sore throat was present. After that, no sore throat was present, sir. On the day 1 itself, they treated it, sir.
Now the point
That
is,
sir.
how many days after the initial sore throat now? That is 4 days. Am I right?
Yes, sir.
Okay.
And knee joint pain was associated with swelling and redness of joint. There was restriction of movement and day-to-day activities. Pain in the knee joint decreased on the following days, and on day 9 of fever.
Was it with treatment or without treatment? Decreased.
Analgesics was paracetamol was taken, sir.
Paracetamol. Okay.
On day 9 of fever, right knee joint pain almost disappeared and pain appeared on the right hip joint, and child was not able to move his hip joint and was completely bedbound. There was no associated morning stiffness present. Mother also
Why did you ask for morning stiffness?
So rheumatoid arthritis.
Okay, good. Okay.
Mother also noticed redness in bilateral eyes. It was not associated with any pain or discharge. No history of any other joint involvement or deformity.
Can you have this eye redness, sore throat, fever together in any condition?
Sir, eye redness, sir, in Kawasaki disease, there can be non-purulent conjunctivitis.
Kawasaki actually, this is 13 year, no? So we must consider Kawasaki lower down, not really as the first answer.
So in any juvenile idiopathic arthritis, there can be uveitis.
In juvenile idiopathic arthritis, you can have uveitis, agree. That of something called pharyngoconjunctival fever. And what is it due to? Because it is common. You must have seen in OPDs. Okay, it is due to adenovirus. You can read about it because it's very common. Once you know it, you will come across it often. Okay, go on.
There was no history of any other joint involvement or deformity. No history of any trauma. No history of chest pain or breathlessness.
Why did you ask for chest pain?
Sorry, sir.
Why did you ask for chest pain?
Sir, keeping rheumatic fever in mind to rule out
what is the reason? What is the reason for chest pain in rheumatic fever?
So in myocarditis.
Myocarditis, is it painful?
Sorry, sir. Pericarditis.
Okay, good. Okay.
Pericarditis, there can be chest pains.
And then what about the breathlessness? Why did you ask?
If there is a congestive heart failure, there can be tachypnea and breathlessness. No history of abnormal movement or seizures. No
Why are you
history of,
asking for abnormal movements?
so to rule out the chorea, CNS involvement, sir.
Chorea. So can you
Yes.
tell us the characteristics of rheumatic chorea?
Rheumatic chorea, it can occur even it has a
What is the
long
difference
latent
between
periods.
chorea and athetosis? Because they usually come together. So what is chorea and what is athetosis? You settle that first and then what is athetosis and what is chorea? Okay, then you describe rheumatic chorea movements.
So chorea is a rapid, irregular,
Very good.
purposeless movement, sir.
Very good, very good.
It a brief
Jerky,
and
jerky. Yeah,
athetosis, slow, continuous writhing movements. Sir.
writhing, correct. So it is like writhing means നമ്മൾ ഈ തോർത്തൊക്കെ പിഴിയുന്നില്ലേ, that is the writhing movement. ആ ഒരു turn. And in addition, anything else you would like to add on to, because chorea can be because of other reasons also. No, suppose you have a basal ganglia problem, you can have extrapyramidal involvement, you can have chorea. So that chorea and this chorea, how does it differ? For example, Huntington's chorea, how does it differ from that?
The rheumatic chorea disappear during sleep and it is aggravated during stress.
Very good. Stress or emotional stress. And of course, the emotional component is very much obvious. They cry, laugh without reasons. So emotional outbursts. Okay, good. Go on.
No history of other swellings over bony prominence. No history of night pain or
what do you have in your mind when you ask for that?
any subcutaneous nodules.
Where do you see subcutaneous? Have you seen it?
Subcutaneous nodules can be seen near tendons.
Tendon means Achilles tendon.
Near extensors. So it can be seen in the near the elbow suboccipital region,
Yes.
over the spine.
Suboccipital is very common, and over your spine process. That is something that you miss unless you look for it. Yes.
Okay.
Of course, extensor you can have. Yes.
Yes. And no history of night pain or loss of weight.
Why night pain, specifically asking for night pain?
To rule out any malignancies.
Malignancy. In arthritis, can you have night pain?
So bone pain.
Excuse me?
So bone pain.
See, in arthritis and all, what happens is your muscle actually keeps your bones apart by contraction. So in night, it simply relaxes and it touches and there is a shooting pain. So in arthritis also, this night pain is common. So good that you asked.
Okay, so no history of petechia or any bleeding tendencies.
Do you really expect petechia and bleeding tendency with your diagnosis? Because first of all, we committed our diagnosis. So with that diagnosis in mind, do you really expect this petechia and bleeding tendency?
Sir, I asked this to rule out basically malignancies.
Malignancy, okay. But in rheumatic fever, can you have, what are the atypical manifestations of rheumatic fever? Can you have epistaxis in rheumatic fever? It was actually there even in the very first Jones criteria, it was there. Now it is not there.
Yes.
So bleeding, because it is basically a immune problem. So it can have bleeding, especially from Little's area.
Okay, sir.
Okay.
No history
For
of
malignancy, you
nail.
can ask, of course. For malignancy, you can definitely ask. Yes.
Yes. And no history of any nail changes or hair loss. No history of any peeling of skin.
Peeling, why you are asking for peeling of skin?
Kawasaki disease, they can be
Can you have a peeling of skin in streptococcus?
Streptococcal pyoderm.
No, actually, according to your history, there was a sore throat for 2 days, fever persisting, and you had a rash which was non-pruritic, which disappeared in 2 days, and then suppose there is a peeling. Now, what you should have in your mind? Sore throat. Suppose it is bacterial. Sore throat.
Okay.
Heard of scarlet fever?
Yes, a scarlet fever.
So what are the manifestations?
So scarlet fever, there can be
Can you have sore
typical
throat?
rash.
Can you have
Yes,
sore
sir.
throat?
Sore throat can
Yes.
be present, sir.
Fever, can you have?
Yes, sir.
Yes. And the
Fever.
rash, can you have?
Yes, sir.
And
Rash
what type of
present.
rash? What type of rash?
Sandpaper rash, sir.
Okay. So that is one of the diagnoses that you will have to keep in mind. Okay, go ahead.
Okay, sir. And there is no history of dysuria.
Why
No
you are asking for dysuria?
Sir, in reactive arthritis, Ritter
very good.
syndrome, there can be.
What are the components of Ritter syndrome? Or
Ritter
rather,
syndrome
what are the components of Ritter syndrome that is there in this patient?
So redness of eyes, there is
Very good.
complaints. Sir, arthritis is also present.
Very good.
So
Only thing is dysuria is missing. Okay, good.
yes. No history of any pedal edema or decreased urine output.
Why decreased urine output you are asking for?
Sir, any congestive cardiac failure?
Very good. In congestive cardiac failure, why there is decreased urine output? You are correct, but why? Because you are accumulating edema, no? So less circulation into the kidney, so less filtration. Simple.
Yes.
Next.
So there will be low cardiac output, sir. So GFR will be reduced.
Very good, correct. Next.
So no history of any loose stools, constipation or abdominal pain.
Why exactly you are asking for loose stools?
Sir, any post reactive arthritis after GI infections like salmonella?
Very good. And why abdominal pain in this case?
Sir, there is also an IBD arthritis.
IBD arthritis. Can you have abdominal pain, rheumatic fever?
Yes, sir. Can have. Initially in the Jones criteria, it was there.
Right now it is not there. It was there originally. Oh, maybe. Okay. I'm not sure. Okay.
There was no history of any travel, sir.
Why? Why you are asking
to
for
rule
that?
out any viral infections moving to endemic areas.
Which viral infection you have in your mind?
Some malaria.
Malaria, the manifestations, of course, we are dealing with a sore throat, rash, and eye redness condition. No?
Parvo, sore throat rash, usually this arthritis parvovirus. The one.
Okay, but
to rule out dengue, chikungunya, viral infections.
Okay. Heard of Lyme disease? Heard of Lyme disease?
Yes, sir. It is caused by Borrelia burgdorferi.
Okay. Can you have arthritis? Can you have arthritis?
Fever. Yes, sir.
Can you have eye manifestation? Can you have rash?
Yes, sir. Typical rash is central clearing.
Very good. Central clearing. What is the typical rash in rheumatic fever?
Erythema marginatum, sir. Serpiginous.
Central clearing or not?
Central clearing is present in rash of rheumatic fever also,
Correct.
sir.
So central clearing is not the characteristic of Lyme. Lyme is something like a bullseye, no? The bite mark, that mark will be there, and then then it spreads. So that is why it is called erythema migrans and all. Okay, leave it.
Sir, after admission, there was no significant fever spikes were recorded.
Why?
So actually, child was started on a medicine following which the
maybe drug effect, because otherwise there is no reason.
Yes. And hip pain was severe. Minimal knee joint pain was persisting without any swelling.
Okay, 1 minute. So possibly paracetamol was given or anti-inflammatory was given. NSAIDs were given.
They were before admission. They were taking paracetamol.
From this history, what do you think?
Salicylates was given, sir. He was started on aspirin, following which the symptoms dramatically improved. And from the second day,
is if it is rheumatic fever and if salicylate is given, it is more likely that both pain of hip and fever comes down rather than fever alone coming down. So here possibly it was paracetamol.
Okay, sir.
I mean, from the history, that is what I can gather. Next.
Okay, sir. And past history, no history of similar illness in the past.
Why do you
History
want to
of
ask
three.
that? Why do you want to ask that? Rheumatic fever, does it run in family? Or
Yes, sir. It can run in the family, sir. Genetic
okay.
predisposition is noted in
Oh, this is
rheumatic
past
fevers.
history. Sorry. I thought it was family. Past history of illness.
Past
Okay.
history, there can be recurrence of rheumatic fever, sir. So
Very good. Okay.
and there is history of 3 hospital admissions in the past, sir, for ARA at 1 year, 1.5 years, and 2 years of age.
Okay.
History of COVID infection in 2020 was managed symptomatically on home basis, sir.
Does it really have a significance here? Well, I mean, according to you, should we take it as significant? Or rather, post-COVID, can you have this eye redness or arthritis, etc., rash, etc.?
Yes, sir, can have post-COVID can have, sir.
How long after
Multi-system.
COVID? How long after COVID? It's too long, no? I mean, it's almost 5 years.
Okay,
So
sir.
we possibly will not consider it. It comes after a few months at the most.
Okay. Okay. And treatment history on day one of illness, they went to a hospital and was treated as a tonsillitis and antibiotics was taken. And on day 5, they went to nearby clinic and managed symptomatically. On day 10 of illness, child was not able to walk and came to our hospital for admissions.
Initial presenting complaint was fever was still persisting, right? On day 10.
Yes, sir.
Am I
Fever
right?
was still persisting, sir.
So is it very likely to be streptococcal sore throat? Because it should respond to amoxiclav usually.
Yeah.
Very unusual that strep is not responding.
Yes.
So that is something that we'll have to keep in mind.
Okay.
I mean, provided the dose and the child has taken it and all. In that case, it is very unlikely that strep is not responding to coamoxiclav.
Okay.
Antibiotic resistance in strep, very unlikely. Very unlikely.
Okay. Sir, antenatal, natal, postnatal history conceived after 1 year of
I think
marriage.
we can skip that.
Yes.
12, 13-year-old child.
Development, age appropriate milestones were achieved, sir. Now in 8th standard with good scholastic performance, no recent change in scholastic performance.
Why that question? No recent change in
Sir,
scholastic performance?
in Korea, there can be poor scholastic performance, sir.
Very. And post-streptococcal, can you have other situations where you can have abnormal mentation?
Sorry, sir, post-streptococcal?
You have abnormal scholastic. Somebody has written pandas. What is this pandas? In comment box, they have written pandas. What is pandas?
The pediatric autoimmune neuropsychiatric disorders
So
associated with.
that can come after streptococcus. So
Yes.
scholastic performance decrease can be because of various reasons. One is, of course, your Korea, because your handwriting goes away. I mean, next.
Yes.
Oh, very good. Nutrition is perfect, right? And usually when your calorie is adequate, the protein will be excess. That is the usual. Here the protein is also just adequate. But generally when calorie is adequate, protein will be in excess. That's what we usually see. Okay, go on.
Okay. And immunization, immunized for age, BCG scar present, sir. Last vaccination, TD at 10 years of age. No
Okay, this
optional vaccines.
tetanus, suppose you take frequently, can it produce arthritis like this? Frequent tetanus vaccination, what can it produce? Suppose every other week, every other month, they get the child gets an injury and comes and take a TT, and you generally discourage that. Why?
It rarely causes arthritis, sir.
Yeah, it is a Arthritis type of reaction. It can cause. At least I have come across one in a doctor. The whole limb was edematous.
Okay, sir.
Go on.
Family history. This first child of non-consanguineous marriage. No history of similar illness in family members. No family history of arthritis, heart disease. No history of tuberculosis in the family, sir.
Okay. Can tuberculosis be considered in this child?
So tuberculosis can cause arthritis, but it's
Very good.
usually monoarticular.
Okay, good. Can it produce eye problems? What is the eye? What are the eye manifestations of tuberculosis? A little away from this subject. Eye manifestation. Suppose you, excuse me.
So scleritis or episcleritis can be
What do you call that
then
in tuberculosis? Okay, you can find out later. Go on.
Okay. And uveitis can be seen. So granulomatous uveitis can be
Uveitis
seen.
can be seen, and in fact, even choroid can be.
Yes. Choroid tubercles
Yeah.
or tuberculomas can be seen.
Correct. Go on.
Socioeconomic history, modified Kutsumi scale belongs to lower middle class. No history suggestive of overcrowding.
Why this overcrowding is important?
So the incidence of rheumatic fever is more in when there is overcrowding.
Very good.
Population overcrowding is there. The incidence can there is an association between overcrowding and rheumatic fever.
Correct. Go on. Okay, you can skip that. Okay. This is the summary. Okay.
About 12-year, 11-month-old child with normal growth and development presented with fever of 10 days with non-deforming migratory.
I think we'll discuss diagnosis after examination. You can go to examination.
Examination. Child was alert, awake, was lying supine in the bed with IV cannula in the left hand. Vitals. Temperature was 99.7. Pulse 90 per minute. Regular rhythm. Normal in volume and character. There was no radiofemoral delay and was felt equally in all vessels. Blood pressure was 116 right upper limb in supine position and lower limb blood pressure was 110/60 millimeters of mercury. Respiratory rate was 24 per minute, regular thoraco-abdominal. Saturation was 99, room air in all four limbs. There was no pallor, icterus cyanosis, clubbing, lymphadenopathy or pedal edema.
No lymphadenopathy, right?
Yes, sir.
Because suppose it is a streptococcal sore throat, how do you differentiate whether it is a bacterial or a strep sore throat versus a viral sore throat?
So there is a criteria.
One of the features is lymphadenopathy, right?
Yes, sir. Swollen tender anterior cervical lymph node can be
that
present.
is missing here. And second thing is its response to co-amoxiclav has been disappointing. So two factors are slightly away from your streptococcal etiology. But that's a clinical thing. We will, on investigation, maybe we will find. Okay. But clinically, these two things are a little odd for streptococcal etiology. Okay, go on.
Okay. And anthropometry, weight was 27 kg, expected was 43. Height was 132 and expected was 154. BMI was 15. SMR Tanner stage 3. Upper limb, lower limb ratio was 0.9:1. Arm span was 133 centimeters.
You are surprised with the anthropometry or you are getting what you have expected?
Sir, while plotting in the growth chart,
Ruchar?
So the weight comes between third and 10th centile, and height also between third and 10th centile, sir.
So the point is his nutrition was pakka normal, right?
Yes.
Calorie was okay, protein was okay. No intervening diseases apart from 2 or 3 ARIs, and has got a normal birth weight. So that child, why should that child go into the third centile? That is surprising. Either the child is having some disease or your nutrition history is wrong or something is, because those two actually do not go together. Don't you think so? Because
Yes,
nutrition
sir.
is pakka normal, na? Absolutely no deficit, and here the child is below the, between third and 10th centile, both height and weight, not just weight. So whatever is there has been going on for a long time, and the child was of normal birth weight, and no real medical illness apart from that ARIs. So that is a bit surprising. So maybe whether the nutritional history is wrong or whether the child is suffering from a long-term illness. So that is something that we will have to keep in mind. Okay, you can go ahead.
And head to foot examination, hair was normal, face no dysmorphism was present, eyes no conjunctival congestion at present, oral cavity no oral ulcers, no dental caries, throat normal. On examination, peeling of skin from fingertips was present, sir, and BCG scar was normal,
And
sir.
what could be the reason for this peeling of skin? Don't say Kawasaki because it is too very unlikely at 13 years. Actually, peeling you must have seen in OP. It's a fairly common thing, especially following these streptococcal. Suppose it was scarlet fever. Even without scarlet fever, you'll have peeling. But scarlet fever typically peels.
Yes, sir.
So peeling is not an unexpected thing. It is expected in streptococcal. Okay, go on.
No perineal desquamation. Lower limb skin was dry.
This you mentioned somewhere else, no? Perineal excursion. We discussed somewhere else. It was there in history. Am I right?
Yes, sir.
Oh.
No palpable or visible subcutaneous nodule present, sir. Spine was normal. And this was the peeling was present and skin was dry. These were the only positive findings in the head to foot examinations. Coming to system examination, musculoskeletal system, right hip joint tenderness was present, restriction of movement was present, no swelling or no local rise in temperature, no redness. The knee joint was normal, no involvement of any other joints. The day of admission, PGALS was not able to do because child was not able to stand.
Understandable. Knee joint, did you look for a patellar tap?
Yes,
actually,
sir. There was no effusion.
Actually, it may not be totally normal because knee was involved significantly. So maybe some effusion may persist. So in exam, it is better that you mention whether you have looked for it or not.
Okay, sir.
Whether you have looked for it or not, just mention you have looked for it. Okay. PGALS, of course. Okay, you can skip.
Okay. So at the day of admission, PGALS was not able to stand on but after starting medication from day 2 onwards, child was able to do almost all the maneuvers in PGALS. The cardiovascular system, pulse was 90 per minute, regular rhythm, normal in volume and character, no radiofemoral delay, felt equally in all vessels. Blood pressure 160 in right upper limb and lower limb BP 110/60. JVP was not elevated. Inspection, shape of precordium normal, no visible pulsations present. On palpation,
you can
the
skip. Skip.
Okay.
Nothing is there, no?
No, sir. No murmur was present. CNS, no abnormal movements.
Auscultation is there
Auscultation S1 was normal, S2 normally split, normal P2, no murmur or additional sound.
okay. The you better mention it as S1 of normal intensity, so that the examiner will know that you know what to look for. Like if it is a carditis, you expect an attenuated intensity. So that is something. I mean, better mention it as of normal intensity.
Okay, sir.
Normal is split, normal P2, no murmur. In addition, you again mention as no S3 rather than additional sounds.
Okay, sir.
Additional sound, of course, you may have your pericardial rub in mind, I think.
Yes.
Because traumatic is a pancarditis, so you can have pericarditis. But basically, it is a diagnosis of a cardiologist. They do the echo and find out rather than we detecting rub. So in exam, it is better that you mention as S1 of normal intensity and no S3. That would be more communicative of your intentions. Next.
Okay, sir. Other systems was normal, sir.
Okay, skip.
A summary: 12-year, 11-month-old boy with normal growth and development presented with fever of 10 days with non-deforming migratory oligoarthritis involving right hip joint and hip joints, along with transient non-pruritic papular rash, non-exudative bilateral conjunctivitis. There was sore throat at the onset of illness. On examination, vitals were stable. He has right hip
Actually,
joint.
you need not mention oligoarthritis. You can mention as did you mention non-deforming? You can just say migratory arthritis, right? You need not put oligo. The reason is this oligo is because of your treatment. Suppose you did not treat, it would have become poly. You have put the child on NSAIDs from day one, so naturally it cannot progress. So,
okay, sir.
Rather than saying oligo, you can just say migratory arthritis.
So differential diagnosis, post-streptococcal reactive arthritis, acute rheumatic fever, or incomplete Kawasaki disease.
I possibly may not be very happy with Kawasaki. We will possibly not consider Kawasaki in this case. The other two, which one would you prefer? Acute rheumatic fever as the first diagnosis, which one would you prefer?
Okay.
PSRA or acute rheumatic fever? Which one do you prefer as the first diagnosis?
Sir, before doing, taking investigations, we should consider post-streptococcal reactive arthritis, sir.
Why?
So because within 10 days itself, the arthritis
very
has
good,
evolved.
Very good.
Short incubation period for post-streptococcal reactive arthritis, sir.
Correct.
And there is no signs of any carditis present. So post-streptococcal reactive arthritis can be taken, but there was a acute rheumatic fever.
Two worries that I have is one, in post-streptococcal reactive arthritis, is the fever this bad? Generally, it is a low-grade fever. It is not the fever like a rheumatic fever. Rheumatic fever is very high grade.
Yes.
So that is something that is odd. And the second thing is in history, you said the response. In 24 to 48 hours, you could do all the PGALs. That is unbelievably fast response, which can occur only in rheumatic fever. I mean, if it occurs, even in rheumatic fever, this fast response is, I mean, it will, the arthritis will respond in 24, 48 hours, but possibly not to the level of examining PGALs. So this is a very rapid response. So that is also not very much in favor of PSRA. So I would possibly put rheumatic as first and PSRA as next. Okay, go on.
Okay. So course in our hospital, child with above mentioned complaints was admitted in our hospital. Routine blood investigations were done, found to have elevated inflammatory markers. Since clinical features and lab investigations were fitting into modified Jones criteria, probable diagnosis of acute rheumatic fever was considered, sir. Discussed with pediatric cardiologist and was started on aspirin. And child showed a dramatic response on starting aspirin. By day 2, child was able to walk. Child improved during the course and child was discharged with oral penicillin prophylaxis, sir.
Oh, discharged. Okay. This is the investigation.
So coming to our
investigation, yeah. Count is increased. Platelet is slightly on the higher side. You have some comment on that?
thrombocytosis is present.
Thrombocytosis due to what? Have you seen thrombocytosis in infections in your
So
wards?
aspirin.
It's in no way related to aspirin. No. Have you seen thrombocytosis in infections in your wards? Now you keep it in mind and look for thrombocytosis in serious infections, right? Not in infections like dengue and all.
Then incomplete KD thrombocytosis.
In inflammation. No. I think you should.
Then acute rheumatoid arthritis.
That albumin also, I'm not very happy. I mean, 3.6 means it's low normal. Are you worried?
Yes, sir.
Why? Is albumin a marker of inflammation?
Yes, sir. Albumin is a
Is it
marker
an
of
acute phase reactant? Is it albumin?
Yes, sir.
Negative correlation. Am I right?
Yes, sir.
So what are the reasons why albumin comes down in inflammation? Does it come down? It does. What is the reason?
So since it is a negative
Very good. Negative
acute
means
phase
it comes
reactant,
down.
decrease in response to inflammation.
Yeah, in inflammation, it comes down. That's why it is called negative. CRP is positive marker because it increases. You got the point, right?
Yes,
Negative
sir.
means it comes down. Positive means it goes up. So ESR is a positive. CRP is a positive marker, but this is a negative marker. It goes down.
Sir. Yes.
My question is, what are the reasons why it is going down? There are so many reasons. You can just read.
Cytokine effect in the leukin.
Yeah. So what happens? So
necrosis
cytokine
factor.
produces inflammation. Inflammation
Albumin
produces
synthesis
leakage.
in the liver is affected.
Yes. If you are very seriously ill, naturally the production in liver suffers. That is true. But more than that, in inflammation, you have inflamed tissue with albumin leakage. So that is another reason. Now the ASO is 530. What is the cutoff?
200, sir.
In rheumatic, actually, you go a little higher because high ASO is more correlated with rheumatic fever than lower ASO. So I think you go by what Nelson says. It used to say something like 300 or 330 or something of that sort. I don't know whether they are sticking on to that now. Excuse me?
We will take the cutoff as 330 and for older children like more than 18 years, 250.
Okay. So 200 is possibly not a...
200 is not. 250 is the one
because
for
we want a higher level because in rheumatic, the ASO will be higher, which means your system is reacting to that in a more vigorous fashion. 200 may diagnose streptococcal infection, but it may not diagnose rheumatic fever. Am I conveying my message, Lakshmi?
Yes, sir. Yes.
Because in rheumatic fever, you actually expect a higher ASO. So 200 possibly really means
students
200 can mean a streptococcal infection, but for rheumatic fever, you want something like 300, 330 or something of that sort.
Okay.
Go on, next.
Yes,
Oh my God,
blood
is positive. Huh? So can it be dengue fever?
Sir, it can be due to cross reaction.
Dengue fever, can it produce a red eye? Can it produce an arthritis? Can it produce fever? Can it produce rash?
Yes, sir. Dengue can produce fever with rash and arthritis.
Can you describe the rash of dengue? You must have seen cases, right?
Yes, sir. So, see in the Isle of Red.
No, that is when dengue is recovering.
Yes.
You have areas of
There
lucency.
can be diffuse flushing or
diffuse flushing, or can you have a scarlet-like rash? That is the point here, because we are finding a scarlet-like rash in this particular child. Can it be there in dengue? It can be, because in dengue there are two or three types of rash possible. One is what you said, but scarlatiform rash is also like.
Okay.
Of course, there are so many things against dengue in this case, but still, once the
Okay.
next. Oh, this is your criteria. Okay, good.
Sir, this fits into modified Jones
Very
criteria. ASO titer was elevated, sir.
Again,
And,
you please don't say that oligo. So once you say oligo, it goes a little away from your diagnosis, right?
Okay.
There is no need. This oligo is actually iatrogenic. You have given anti-inflammatory, and that's why it became oligo.
Okay, sir. So polyarthritis was present and minor criteria.
You can just
fever.
say arthritis.
Okay, so
Don't
arthritis.
mention. I mean,
One major criteria and
yes,
two minor criteria was present with evidence of recent streptococcal
very
infection
good.
was present.
So now it
So
looks
the
like rheumatic fever. Okay.
rheumatic fevers. So which echo was done, sir, echo, to rule out any clinically no carditis was present. To rule out subclinical carditis, echo was also done. ECG was done to look PR interval, sir.
Okay. What was the PR interval?
0.16, sir.
Okay. How do you measure PR interval from which point to which point?
The beginning of P wave to
cardiologist is there, so I
the
will
start
not
of P
dwell
wave
on
to
that.
beginning of QRS PR interval is calculated, sir. The normal duration is 0.12 to 0.2 seconds, sir.
0.2 is general. Yeah, this is 13-year-old. Okay,
Yes.
maybe a little over 0.1, but even then over 0.16 will take it as prolonged.
Okay.
To 0.2 is normal in an adult. Now that I agree. Next.
Okay. Coming to treatment, sir. Bed rest was advised. The aspirin was started, sir.
Bed rest for how long?
Bed rest for 3 weeks.
Why 3 weeks? Why not 4 weeks? Why not 6 weeks?
So with the arthritis alone is here arthritis alone is present.
Okay. So arthritis is actually almost over in 48 hours. No, you are doing P-gals and all. So why can't the child move around? Somebody's mic is on. Can the host mute? And can the host mute all and then unmute us? Okay, bed rest for how long? Why not up to 6 weeks? you said arthritis, but arthritis is over. Now why can't the child move around? That's my question. You got the question, Lakshmi?
Yes, sir.
Can host mute all and
Please.
then unmute us?
Yes.
ഇതിന്റെ പേരില് ഇവിടെ വിടാനുള്ള തീരുമാനം അപ്പൊ അവർ ചെയ്തു. എനിക്കിഷ്ടമല്ല.
സാറ് അൺമ്യൂട്ട് ചെയ്താൽ മതി സാർ ഇനി.
ഞാൻ അൺമ്യൂട്ട് ആക്കി.
ആ പറഞ്ഞ ആളിനെ ഇപ്പൊ ആക്കിയിട്ടില്ലേ ഈ ഒരു കാര്യം അല്ലെങ്കിൽ എന്നെ ഒന്ന് കോഹോസ്റ്റ് ആക്കിയാൽ മതിയായിരുന്നു.
സാറ് കോഹോസ്റ്റ് ആണ് സാർ. സാറിന് മ്യൂട്ട് ചെയ്യാം, ആരെ വേണേലും മ്യൂട്ട് ചെയ്യാം.
ഓക്കെ, എനിക്ക് അറിയില്ലായിരുന്നു. ഓക്കെ, കുഴപ്പമില്ല. ഇങ്ങനത്തെ ശല്യപ്പെടുത്തുന്ന ആൾക്കാർ കയറാതിരിക്കുക. അത് ആരാണോ എന്ന് അറിയേണ്ട കാര്യമില്ല. സീനിയർ ആണോ ജൂനിയർ ആണോ ആരാണെങ്കിലും ഇത്തരത്തിലുള്ള പ്രോഗ്രാം ഒക്കെ ഒരു ബുദ്ധിമുട്ടാക്കുന്ന ആൾക്കാർ കയറാതിരിക്കുക. ദാറ്റ് ഇസ് ഇൻഡീസെൻസി. Sir, you continue.
Lakshmi, can we continue? Lakshmi, are you muted?
ലക്ഷ്മിയും തന്നെ അൺമ്യൂട്ട് ചെയ്താൽ മതി. ലക്ഷ്മിക്ക് അൺമ്യൂട്ട് ചെയ്യാൻ പറ്റും. അൺമ്യൂട്ട് ചെയ്ത് സംസാരിച്ചോളൂ.
Sir.
Okay, Lakshmi. Our question was why bed rest for just for 3 weeks? Because the child is already walking around. So
increased physical activity can increase heart rate and workload, sir, which can worsen the inflammation.
So the point is the chance of your having carditis is maximum in the first 2 weeks. So first 2 weeks bed rest is mandatory. So if you want 3 weeks, that is also acceptable. If you are destined to develop carditis, you will develop in 2 weeks. So that is why you keep him in bed, although he can walk around. Because in 2-3 days, the arthritis is gone and he can actually walk around. But we do not want. The point is, we are fearing that carditis can occur in the next few days. So that is why.
Okay,
so
sir.
if you, but suppose you already have carditis, then your bed rest will not end in 2 or 3 weeks. It will go on, depending on whether there is cardiac failure or not.
Okay, sir.
Aspirin for 3 days, and after that, what happens? You said 70 milligram per kilogram for 3 days.
Aspirin for first 3 days, followed by 50 mg per kg per day.
How long?
Divided into 4 doses for 3 weeks, sir. Then followed by half dose daily for 4 to 6 weeks, sir.
Okay. So when will you give steroids?
Carditis with cardiomegaly or congestive heart failure, oral prednisolone is advised, sir.
How much and how long?
2 mg per kg per day, sir, for 2 to 3 weeks, followed by half the dose for 2 to 3 weeks. And then we will taper 5 mg per 24 hour for 2 to 3 days.
Good.
On
So
tapering,
here, aspirin actually you started tapering after 3 weeks. Here you are going for 4 to 6 weeks. Why? When you are giving steroid, which is a stronger anti-inflammatory, you are giving for a longer duration. Why?
here carditis.
Very good, very good. Because there is
carditis
and that's why you want to give it longer. I mean, this using of steroid, does it prevent development of rheumatic heart disease later on?
No, sir. For that, we should give prophylaxis.
That is my question is, you are giving adequate prophylaxis. There is no recurrence. There is just one rheumatic fever and one rheumatic carditis, and you have given steroid. Will it prevent rheumatic heart disease later on? You know,
Yeah.
rheumatic heart disease is different from the acute carditis, is it not?
Yes.
Acute carditis is not rheumatic heart disease.
Yes,
That
sir.
is an acute carditis. Which what happens to acute carditis? What is the usual lesion in acute carditis?
In acute carditis, usually in rheumatic fever, pancarditis is seen. Mitral valve is affected, sir.
Okay. What?
Mitral regurgitation.
Okay. You said pancarditis. What are the manifestations of pancarditis clinically?
Sir, same pancarditis, if pericarditis is involved, there can be pericardial drug. Then
Yes.
murmur can be present, sir.
Murmur is endocarditis, no? Murmur is
In endocarditis, murmur can be present, sir.
Good,
Systolic murmur more in the apex radiating to axilla.
Very good, very good. And myocarditis? Manifestation of myocarditis? Can it be cardiac
Myocarditis,
failure?
there can be tachycardia.
Very good, very good. Tachycardia. Tachycardia, I mean, do you actually take sleeping pulse rate? It used to be. Nowadays, we are not taking. What is the
Yes, the
importance of
sleeping pulse rate was taken, sir. Sleeping pulse rate was.
So, I mean, in rheumatic fever, the cardiac failure, is it due to myocarditis or because of the mitral regurgitation? What do you think? Which is more likely?
Mitral regurgitation.
Yes, the cardiac failure in rheumatic fever is actually due to mitral regurgitation, not really due to myocarditis. If you are going in, if you are getting a cardiac failure due to myocarditis, I'll think in more in terms of viral myocarditis, which is actually is a disease of a younger child, not really a 10, 13-year-old child. But cardiac failure due to myocarditis, I would rather think in terms of viral myocarditis rather than rheumatic. In rheumatic, cardiac failure is basically because they leak. You said you have a systolic murmur, but can you have a diastolic murmur in acute carditis?
Yes, sir. Diastolic murmur due to
what do you call
mitral Carey-Coombs murmurs, sir.
Can you have a description of that?
Sir, mid-diastolic murmur due to inflammation of mitral valve.
How does it differ from the established mitral stenosis?
Sir, this is due to this is a relative mitral stenosis due to inflammation of
when you are listening to it, what difference do you feel? You are auscultating. You have Carey-Coombs murmur here and mitral stenosis murmur in the next patient. What are the differences? Acoustic differences. Okay, I'll send you the I'll send you mitral stenosis murmur for you to listen to it. Okay, because you cannot have a organic mitral stenosis murmur confused with any other murmur. It's so typical. Yeah. The other one is only mid-systolic. The Carey-Coombs is only mid-systolic. Sort of, I think since Dr. Alka is there, I will not discuss that part.
No, sir, you discuss it.
Alka അത് പറഞ്ഞാൽ മതി കേട്ടോ.
Sherry, so if you have a proper MS murmur, you will have a loud S1 mid-diastolic murmur with pre-systolic accentuation. But in our regular Carey-Coombs murmur, it will be just a mid-systolic murmur. Sorry, mid-diastolic murmur. That's all.
Mid-diastolic, and it is very subdued murmur. The other one is very loud. That's what I'll send you, Lakshmi, for you to have a feel of that. Azithromycin. Oh, you have given azithromycin, right?
Yes, sir.
Penicillin. Why 21 years? What is the... Why 21 years?
Acute rheumatic fever without carditis, the prophylaxis is 5 years or until 21 years, whichever is longer, sir.
Okay, why you want to stop at 21 years? Why can't you give it at till 40 years or maybe 45 years? The point is, the usual age group of rheumatic fever is over. No, it's 5 to 15. So in adult, it is less likely. That is one. Second thing, in adult, even if you have a rheumatic fever, acute rheumatic fever, it is more of an arthritis and less of carditis. Almost never, first time rheumatic fever in an adult will not have carditis, usually. Will not have chorea, will not have erythema marginatum. Those things are all with children. And in fact, when you are much younger, all these things are more likely. For example, what is the usual age group of chorea, Lakshmi? Are you there, Lakshmi? Am I audible, Lakshmi?
Yes, sir. Yes, sir. You are audible, sir.
Okay, Lakshmi. It is in school age child, the chorea. And these...
Sir, Korea usually in 5 to school age, 5 to 15 years of age.
Correct. You generally will not have chorea in an adult due to rheumatic. The subcutaneous nodule, even smaller children. What is the relation between subcutaneous nodule and carditis?
Sir, if subcutaneous nodule is there, there can be more chance of
High chance of
can be.
carditis. Very good.
Yes.
High chance of cardiac involvement is there.
Yes, sir.
So the chance of rheumatic fever is less in adult. If at all it comes, it is more of an arthritis. And lastly, the rheumatic fever follows a pattern. If rheumatic fever this time was only arthritis, next time also it is more likely to be arthritis. So it is safe to stop at 21. That is why they stop at 21. Suppose you have a carditis also, then how long will you go on with prophylaxis?
Rheumatic fever with carditis, if there is residual heart disease also present 10 years or until 40 years of age, whichever is longer. Or if acute rheumatic fever without carditis but with residual heart disease 10 year or until 20
without residual carditis. Had an acute carditis, no established heart disease. Then how long will you give the prophylaxis?
10 year or until 21 year, whichever is longer.
Okay, good. The reason is same. In the investigation, you said there is fluid in by ultrasound, right? Suppose you tap, joint fluid is there both in hip and knee. That's what you said. Suppose you tap, what will be the finding?
In rheumatic fever, if you tap, there can be WBC 10,000 to 1 lakh with neutrophilic predominance. And normal glucose protein can be 4 per deciliter and good mucin count can be seen.
Yeah, protein will be high. So the to differentiate between pyogenic and this one is glucose is normal. Second, culture will be negative. So those are the two things that the other things are like pyogenic only. So that will not give you a clue as to whether it is bacterial or rheumatic. Then your ASO was 500. Suppose the ASO is low, then what other thing can you do?
We can do anti-DNSB.
Why?
Because even when the ASO is low, the anti-DNSB will be high.
Why? The point is anti-DNA actually lasts longer. So in this particular case, it doesn't really matter because it's a very hyperacute onset. So maybe it is, ASO is only on the way to peak. It may even go beyond this 530. So the thing is, in a late case, for example, it is only a chorea. Then your ASO may be negative.
Yes, sir.
There it may help because anti-DNAs that last longer. Maybe 2, 3, or maybe 4 months it may last. So there we can do, otherwise no. Otherwise no means it doesn't really give any benefit of extra spending. Okay, anything else in this? Anything else?
Hyaluronidase.
Okay. Multiple antibodies, of course, adds strength to the diagram. Any more slide or over?
Over, sir.
Okay. So what can we do for the prevention of this streptococcal infection?
Prophylaxis.
That
There
is
can be primary prevention and secondary prevention, sir.
okay.
In
For
primary prevention,
Hmm.
primary appropriate, we should give antibiotic therapy before the
Mhm.
9th day of symptoms, sir.
Okay.
This one.
Can you have vaccines? So what is your comment about streptococcal vaccines? Vaccine, they generally target the M antigen. But it has not been successful. Why? One is M is strain specific. So many M's are there. So it's not a easy thing. That is one thing. And another thing is all rheumatogenic strains do not have M. That is also another issue. And the third issue is people are afraid because all these things are because of antigenic mimicry, So something very similar to M is there in myocardium. So suppose you give the vaccine, whether the antibodies will go and attack that also. So people are afraid also.
Yes, sir.
Now, suppose you have, when was this child discharged?
The child was discharged after 5 days of admission, sir.
That means now how many days now?
Now about 2 weeks, sir.
2 weeks.
Child has come to OPD for review.
Child has come to OPD for review. Okay.
Yes, sir.
Suppose child has come to OPD for review at 1 month. And the child is saying, after 1 week, I stopped all these things. Now on no drug. Now, what is your way ahead? Child is saying, I was okay, no pain, no fever, so I stopped everything after 1 week. Now I'm off drugs, or maybe after 2 weeks. Now off drugs for 2 weeks. At 1 month, the child is with you, and now your dilemma is what to do. So what is your mode of action?
We should restart penicillin prophylaxis.
Penicillin prophylaxis, of course, he is taking. He stopped anti-inflammatory because aspirin too much tablet and too much of discomfort to the stomach. So they stopped. Now they are continuing Pendit, but not aspirin. Now, what is your point? What is your way ahead?
We are advised to continue.
No, you do the acute phase reactants. If it has come down, see, for example, you are giving aspirin for 2 weeks, then you are doing the ESR, making sure that it has come down, then only you reduce, right? Am I right?
Yes, sir. Yes, sir.
So here, suppose you do ESR and it is only 10. That means the natural history
Inflammation
of
is reduced.
natural history of this rheumatic fever of this child is over.
Yes,
Then
sir.
there is no point in continuing restarting anti-inflammatory, because
Okay.
anti-inflammatory we know only control the symptom. It doesn't really prevent long-term heart disease.
Okay, sir.
So if the usual course of action is you do the acute phase reactants, inflammation, if it is there, you will restart. Definitely you will restart. But if inflammation is absolutely nothing, like ESR of 10 means no inflammation at all. There is no point in restarting.
Okay, sir.
And any other manifestation of rheumatic fever where you will not start anti-inflammatory? Any rheumatic manifestation where you will not start anti-inflammatory?
Korea.
Very good, very good. Korea, you will not start anti-inflammatory. How do you treat Korea?
Sir, Korea can be treated with phenobarbital or haloperidol,
We
chlorpromazine.
usually use haloperidol. Phenobarbital we used to use. Nowadays we are not using. Haloperidol is a drug that we, or at least I use.
Okay.
In fact, I use non-standard drugs also, like steroid. Okay. So haloperidol. What is the dose of haloperidol? What is the tablet strength of haloperidol? That means you have not used it so far. Okay. Doesn't matter. Doesn't
The
matter.
haloperidol 0.25 mg,
Yeah,
0.5 mg
Okay.
tablet strength.
Okay. Now, what else? Dr. Alka, എന്തെങ്കിലും ഡിസ്കസ് ചെയ്യാനുണ്ടെങ്കിൽ ചെയ്യൂ.
Lakshmi, you started penicillin, oral penicillin, right?
Yes,
Ideally, which is the ideal one which you should start?
ma'am, ideally we should give benzathine penicillin, injectable penicillin for
How
more
much?
than 27 kg, 1.2 million international unit every 4 weeks. Less than or equal to 27 kg, 0.6 million
Is
international.
it currently, is it every 4 weeks or every 3 weeks? And if so, why?
In high risk situations, administration every 3 weeks is recommended.
Because by 4th week, the level is so low that it may not prevent recurrence. So, I mean, recurrence of streptococcal infection. So, every 3 weeks is ideal.
Okay,
And the difference in criteria of, I mean, John's criteria revised as per area of endemicity and low
latest
or high risk.
revision,
That
2015, America Heart Association has considered low
Yes.
risk and high risk. Low risk population, acute rheumatic fever less than or equal to 2 per 1 lakh school aged children, or rheumatic heart disease less than or equal to 1 per 1,000 on all age.
So, how does criteria differ depending upon
Criteria coming to arthritis in low risk population, polyarthritis only is considered in major criteria, but moderate to high risk monoarthritis and polyarthralgia is also considered.
Good.
Then in the minor criteria, sir, in low risk fever more than or equal to 38.5, but in high risk more than or equal to 38. The acute phase reactant ESR more than or equal to 60 millimeters in low risk and more than or equal to 30 millimeters in high risk. Then polyarthralgia is a minor criteria in low risk, but it is a major criteria in moderate to high risk.
Enough. Okay. So,
Lakshmi,
Dr. Alka, if you can add.
like what is the incidence of the prevalence of RHD in India? Any idea? Like, are we high risk or are we low risk?
We high risk, ma'am.
Okay. So number, any idea? Just there are various studies, actually show various numbers, but it is around, it differs, there is a wide range, or 7.7 per 1,000 ആണ് general അതായിട്ട് പറയുന്നത്. But in Kerala and all, it is like around 1.
Okay.
Okay, I think Lakshmi, you have presented well.
Thank you.
When questions are being asked, there's a little lack of confidence. You need not, because you have read very well. So be very confident and answer. Otherwise, your knowledge level is very good. Absolutely no issues. But then a few practical points, of course, that you will pick up only when you start practicing.
Okay.
So congrats. Okay.
Thank you.
Over to State President is there. Over to State President.
So happy to listen to sir's class after a long time. I think Lakshmi has presented very well, as sir has commented. And regarding this hard sounds and all, I think now this hard sounds and all are actually available in the internet also. We can actually train our ears by using that also. And I have asked Santosh sir to conduct a clinical skill workshop. I think it will be coming in 1 or 2 months, where all the clinical findings will be demonstrated.
But President asked me to do it for undergraduate, no?
No, sir. for postgraduates only. So any comments from senior teachers here? Any more points to be added, or
Dr. Rias.
Dr.
Rias Sunil.
Sir. Purushothaman sir ഉണ്ടല്ലോ. പറഞ്ഞു സുനിൽ സാർ പറഞ്ഞു.
ജസ്റ്റ് ഒരു കാര്യം, ഞാൻ എക്സാമിന് അപ്പിയർ ചെയ്തപ്പോ എന്റെ എക്സാമിനർ എന്റെ അടുത്ത് ചോദിച്ചത് വാട്ട് ഈസ് പുവർ മാൻ CCG എന്ന് ചോദിച്ചു. ഇൻ എ കേസ് ഓഫ് റൂമാറ്റിക് ഫീവർ.
ഓക്കെ.
ലക്ഷ്മി പറയാമോ? ലക്ഷ്മി
കേൾക്കുന്നുണ്ടോ? ഒന്ന് അറ്റംപ്റ്റ് ചെയ്ത് നോക്കൂ.
ലക്ഷ്മി ആൻസർ ചെയ്യാമോ? വാട്ട് ഈസ് പുവർ മാൻ CCG ഇൻ എ ചൈൽഡ് വിത്ത് റൂമാറ്റിക് ഫീവർ?
JVP or carotid pulse?
അല്ല. ഞാൻ ക്ലൂ തരാം. ഇറ്റ് ഈസ് സംതിങ് ടു ഡു വിത്ത് കാർഡൈറ്റിസ്. ഹലോ, ഇവിടെ നമ്മുടെ ടീച്ചേഴ്സ് എല്ലാവരും ഇരിക്കുമ്പോ സത്യം പറഞ്ഞ ഇതൊരു വീണ്ടും സന്തോഷ് കുമാറിന്റെ സാറ് പണ്ടത്തെ ക്ലാസ് അറ്റൻഡ് ചെയ്ത ഫീലിംഗ് ആണ്. റിയലി വെരി ഫോർച്ചുനേറ്റ് ടു അറ്റൻഡ് ദിസ് സെഷൻ. സോ പുവർ മാൻ CCG എന്ന് ഉദ്ദേശിക്കുന്നത്, എനിക്ക് പറഞ്ഞു തന്നത്, ഇറ്റ് ഈസ് സബ്കുട്ടേനിയസ് നോഡ്യൂൾസ്. കാരണം if there is subcutaneous nodules, it is very painless nodules which are usually seen around the joints.
Yes.
So if there are nodules are there, definitely it is associated with carditis, severe carditis. അപ്പൊ നമുക്ക് വേണമെങ്കിൽ ഒരു ECG അവോയ്ഡ് ചെയ്യാം. സർ, സന്തോഷ് കുമാർ സാർ, ഞാൻ പറഞ്ഞത് ശരിയാണോ സർ?
Yes, almost 100% carditis will be there in case of subcutaneous nodule, and more or less same with erythema marginatum also. Erythema marginatum very rare to see. I have seen it once in I think it was before Dr. Rias came. It was in Ward 3, some 12-year-old child.
നമ്മളിപ്പോ ഈ റൊമാറ്റിക് ഫീവർ അങ്ങനെ കാണുന്നില്ലല്ലോ സാറേ. കൊറിയൊക്കെ ഞങ്ങൾ PGs ആയിരുന്നപ്പോഴൊക്കെ നമ്മളൊക്കെ കണ്ടിട്ടുണ്ട്. പക്ഷെ നമ്മുടെയൊക്കെ PGs അത് കാണുന്നുണ്ടോ എന്ന് അറിയില്ല. പുരുഷോത്തമൻ സർ.
Lakshmi, will you please stop sharing the screen? Lakshmi? Okay. Excellent discussion as expected, Santosh sir.
Thank you.
And in the history part, as sir was pointing out, the growth totally unexpected situation. In that situation, there must be something, is as sir pointed out. Always mention the height and weight of the parents also in the growth chart that you didn't do. And history with this fever, rash and all, the PSRA comes as a very high possibility. And other viral infections also, sir said the adenovirus, sometimes rubella, Zika, and other virus also will have this combination of joint conjunctival congestion, that situation. Of course, when the blood is taken, the low count is not there, it's a high count and neutrophilia. So many of the viral things are out. Out of the infections comes the streptococcal and rickettsials also we need to consider in the point. And,
Okay, sir.
and in the discussion, I think the hip joint with effusion a bit unlikely in rheumatic, and there the dominant possibility of a PSRA comes. Otherwise, definitely rheumatic also need to be considered. The hip joint involvement with effusion is a point which is arguing for PSRA. That is one point. Then in the treatment part, which guidelines you followed, Lakshmi? So I'm not convinced about the guidelines. 2015 also, where is it said that aspirin 70 days for 3 days and then for 3 weeks and all? Actually, arthritis only situation. Is there any need for anti-inflammatory? Sometimes Santosh sir said it is not going to modify anyway the final outcome. Whether to treat with anti-inflammatory itself sometimes can, even if you avoid, nothing will happen. So should we give 70 milligrams per kg of aspirin? And if so, 3 days then tapering. And those guidelines, which guidelines you followed? It's not there in 2015 guidelines also. And about the prophylaxis, is it 21 years? Arthritis only, no carditis, no cardiomegaly. So it is 12 plus 5, that is less than 18, or 18, whichever is later. So is it 21? So which guideline did you follow?
Sir, in the latest Nelson, it's written till 21 years, sir.
Okay, Lakshmi, I mean, as sir was saying, there is confusion regarding WHO guideline and Nelson guideline. So in exam, you can say whichever book you are following, because you can't really go on following so many guidelines. But WHO is definitely different, as sir said. WHO is definitely different. But if you are following Nelson, I think in exam it will be accepted.
I didn't go through Nelson, sir. That's why I was having the impression of the other one. That's why. And
Alka, Alka can clarify. Alka. Unmute.
Sir, actually, there are different guidelines, and whichever we are following, we have to follow that. Like we should, but when we are treating patients, we have to treat them uniformly. Anti-inflammatory some guidelines say naproxen is better. Australian guidelines okay, naproxen madi ennaanu parayanathu, but still we give. Usually we give how our WHO guidelines are saying, like 70 per kg, but actually 70 per kg and tinnitus, gastritis, they are asking to decrease the dose. So some of them are saying 50 per kg and madina. But whatever guidelines we are following in our hospital, we have to follow it uniformly. That is the main thing.
Indian guidelines are
as such അങ്ങനെയില്ല സർ നമ്മുടെ IAP-യുടെ ഗൈഡ്ലൈൻസിൽ IAP-യുടെ മറ്റേ
there is some pediatric cardiologist association ഒരു guidelines in detail about സാർ ചോദിക്കണ്ടായിരുന്നല്ലോ cut off of 333 and DNAB-ന്റെ ലെവൽ 200 അങ്ങനെയുള്ള കാര്യങ്ങളൊക്കെ ആയിട്ട് സുൽഫി സാറിന്റെ എഴുതിയിരിക്കുന്ന ഒരു ഗൈഡ്ലൈൻസ് in detail ഉണ്ട്. That came even before 2015.
Yes,
അതാണല്ലോ സാർ നമ്മളൊക്കെ പഠിച്ചത്.
That's a very good thing. But nowadays, after that, the incidence of rheumatic fever in Kerala has gone down. So should we consider our state as a high or a low? It comes actually, it's less than 1 now, most likely. So thank you, sir, for the excellent discussion, and Lakshmi also. So even though the last part I didn't read Nelson, that's why I questioned that.
Okay.
Thank you.
So I think it was a great learning session. And even though there were heavy rains all over the state, the Zoom was full. And it is only because of the presence of Santosh sir, I think. Everyone has joined. It was a useful session.
Yes, a very
So,
useful session.
yeah. Thank you, everyone. So we will have the next session next Thursday. Thank you.
Thank you, sir.
Thank you.
Good night. Good
Thank
night.
you. Good night. Night.
Thank you, sir.